All right, here we go. All right, welcome everybody. It's July 11th, Friday, 11 a.m. Eastern Time. And this is the Florida EMS webinar. And we have a huge showing today. And I knew we were going to do this. We're on LinkedIn Live as well. And someone who's been with us for many years and someone who's become a very good friend of mine is Dr. Jonathan Apfelbaum, South Metro Fire Rescue, which is in Colorado. Very, very big agency. A lot of paramedics, a lot of calls every year. And this is somebody who not only knows his numbers, he knows his people, he's loved by his people. It's just one of these departments that we all aspire to be like. And so today, this is a paper that he wrote with his team on POCUS and looking at the FAST exam in EMS and potentially what it could do for us. And I know many of you on the call do this already. I know David Long, I would love to hear from David afterwards. But without any further ado, Jonathan, thank you so much for joining us and take it away, my friend.
Thank you so much for having me. I really appreciate it. And with quite the accolade, I'm not sure where to follow with that. But uh, anyway, I'm John Apfelbaum. I'm the medical director for South Metro, which is the south side of Denver, kind of the larger Denver metro area. We're a department of about 820 people or so, covering just under 300 square miles, just under 600,000 people or so. One of the programs we've been involved with was doing pre-hospital point-of-care ultrasound, so our POCUS program. To give you a little bit of background on that, we started this around 2017. The initial question was, well, can we teach paramedics how to do point-of-care ultrasound? So we started with a feasibility study proving that we could get accurate information from our medics. And we worked with Denver Health's program, with their ultrasound program there, to validate it and have an extra set of eyes and also an external viewpoint, because, obviously we think everyone's above average and, prettier than normal and everything else. So having a set of eyes that's external that could give us accurate feedback was invaluable. So once we proved that our folks could do accurate point of care ultrasounds, we then started with using it for termination of resuscitation, documenting cardiac standstill as one more point of data before we decided to pronounce somebody in the field. And I saw New Orleans up there. We're sharing some data with them for the folks we've seen on ultrasound still having contractility, but appeared to be in PEA, and that's been a different little subset there. Then as time went by, there was that little COVID thing. At that point, we started using ultrasound, trying to get a good or a better image of lungs. There was a short period of time in the beginning when we talked about trying to send patients we were suspicious for COVID of to a single hospital or a single hospital system to try and consolidate that. And of course, that didn't last very long. But that was very good to be able to uh, open the door to start using ultrasound for lungs. So pleural sliding, looking for pneumos, but also looking at lung parenchyma. So what were we seeing? Does this look like a normal lung? Does this look like COVID? Does this look like congestive heart failure? Are we seeing, more of a diffuse haziness, whichever. And then from that, the next natural step was using it for EFAST, for trauma. And we started doing that in 2021. And this paper is actually from the data from 2022. And the question for this was, how accurate are our people with recognizing, oh, there's James. Uh, um, how accurate are our people with recognizing free fluid with markers of trauma? So the data from 2022 had an N of 64. Every medic who does ultrasound, who did the EFAS course, whichever, we do a day-long comprehensive training program where we get a number of models and a number of instructors. So ultrasound trained EM docs in the community, some of our medics who are what we call our super users, who are extremely motivated and knowledgeable. And so every class, we start slow, we have a didactic portion, and then have each student with a instructor one-on-one with a model. And we start slow, 10 minutes to do a basic fast exam. And then as the day goes on, we shorten the time. So it goes from 10 minutes to 8 minutes to 6 minutes to 2 minutes. And at the end, they're getting about a minute and a half per patient, and we keep cycling through. So you go from one instructor to another. So you're hearing a different way of somebody presenting. You're seeing different models, different anatomy, different. Some people have had different, different physiology, different. Someone's had the gallbladder out, whichever. And so at the end of the day, they've had between 25 and 50 hands-on ultrasound experiences. And then we say, okay, let's see how you do in the field. And every ultrasound is recorded. Every ultrasound is overread by our colleagues at Denver Health. We've partnered with their ultrasound program, and their ultrasound fellowship director, Amanda Tony, is just, she's absolutely awesome. And she does real-time feedback in terms of looking at every ultrasound within a day or two and getting people feedback in terms of did they do a good job? What work they improve, et cetera. So based on that, for 2022, we had 64 patients who had EFAST exams. Sorry about the background noise. Of this, 63% were male. The average age was 46. Of that, the sensitivity was 80%. The specificity was 95.8%. The positive predictive value was 50%, but our negative predictive value was just under 96%. For the folks that we had with false positives, the issues were generally body habitus or someone whose anatomy wasn't entirely straightforward. So based on that, we've been using that stepwise going forward. So, okay, one, where can we improve our training? Where can we improve our feedback? And how can we get even better numbers? But then also collaborating with our hospital systems. So our catchment area, we transport to 4 different hospital systems. Of those within our catchment area, we have on the fringes, we have one level 1 trauma center within our district. We have 3 level 2 trauma centers. Um, and then just outside the district, we have another level 1 and another level 2. So we're transported to a number of different systems. So it's not always a direct relationship between our medics and whoever's on for trauma. And some folks for trauma are more receptive. Some are still like, what are these medics doing with ultrasound? But the places that we transport to the most are, we've been developing a relationship with them to the point that now we're looking at the data from 2023 and 2024, where we have more than a handful of patients who've gone direct to OR based on the POCUS results. And they were, oop,
Yeah,
Jeff, is everyone, I see audio issue.
yeah, I think for whatever reason your mic volume is good,
Okay,
and then it goes down. So I'm not sure if it's like the wind in the background. That's
it could be I'm outside. So,
there you go. Now it's better.
okay,
Yeah,
well,
and it could be it could be him moving his head back far enough away from the mic. That's all where it is. Yeah,
all right, I'll stay still.
yeah. Right. We're gonna
Um,
we'll put a lock on your head, John.
There we go. Crazy glue. So I was saying we've had more than a handful of patients who've gone direct to the OR based upon the POCUS. So we've had a lady that stabbed wound in the chest with a pericardial effusion. We've had 2 ectopics with bellies full of blood,
Wow.
and a handful of other ones. So really looking forward to crunching the rest of the data as we get more information and how can we expedite and shorten our time for patients who need to go direct to the OR without waiting to repeat their POCUS exam, without waiting for additional workup otherwise. So kind of an exciting time. We're looking forward to what we're doing and where we can go next.
So I have a few questions. Obviously, this is a very mature program, right? You would say that 2017 is when you started. How many people are you training up of the 800 some odd people? You're not training up everybody.
No. So initially we started with a smaller group of medics, people who were interested. So that was about 30 to 40. And then about 2/3 of those have become our super users. And then as we got more experience, we opened it to all of the medics. So of their 820 people, about 250 or so are medics. Um, of those, probably about 180 now are trained. We're making it a requirement for new hires as people move, join our system and as part of their onboarding to get trained in ultrasound and become facile with it. We, some folks are a little more older school and they're like, this is kind of late in my career for ultrasound. I'm not as enthusiastic about it. and certainly trying to encourage people and trying to get buy-in from that. At the same time, trying to get enough experience and hands-on and feedback to keep people up to date.
So you actually started answering my next question, where we've been using ultrasound for a long time, and what I've noticed, we've trained only our EMS captains, and what I've noticed is that there is a small group of EMS captains who have taken this thing on, head first, and they're like really good at it, and then there are those who, if they don't look at it, hopefully they never have to use it, kind of thing. Have you noticed the same thing? Is that what you're seeing?
Yeah, unfortunately, we actually have, so we have 19 ambulances on the street at any one time, and every ambulance has a Butterfly 3 on it.
Butterfly 3, okay.
So each ambulance has a dedicated ultrasound probe. They have a charger that's hardwired in, so they can just plug it right in and keep it charged there. Some folks are more excited about it than others. So yeah, we definitely have our super users. We definitely have our infrequent users.
Sorry, yeah, I muted them. Okay. Well, and I'm gonna have Tanner come in a second, but here's really the main question that there are people here probably thinking, which is, you know, is this ultrasound really changing your management? Is it really changing where you're transporting the patient? So I think that's really the question that I would love to hear your answer to see whether the expense, whether the training, time and energy, and the follow-up and the connection with Denver Health and all that, is the juice worth the squeeze, as the saying goes?
Peter, before you go on, because I want to spin off of what you just said, do you see an age difference, by the way, generational difference on those people?
Oh, okay, good question.
Yeah,
Um,
but okay, go ahead.
It's a little bit hit or miss. Mostly, yes, the younger folks are much more interested in the technology, kind of like what we're seeing with new hires in our emergency medicine group. The younger docs coming out of residency are all up on ultrasound and quite comfortable with it. The older docs are like, "Oh yeah, I remember hearing about that." Um, so there is that component, absolutely.
Yeah.
In terms of destination, there's a couple spin-outs or spin-offs in terms of data that have come from here, or come from that. One is our Terminal Center for Resuscitation for cardiac arrest rate is higher than the national average. So I think the national average based on CARES data was about
40.
44, 46%, somewhere in there.
Yep.
And we're about 58%.
Wow.
So having one more point of data looking and saying, hey, look, we have, cardiac standstill, we've got nothing. We've worked them for 30 minutes. We have nothing more else to offer. One more data point that people feel, I wouldn't say good about calling it, but better or more comfortable about calling it. So, go ahead.
But hold on a second, because I want to make sure everyone understands that you have some of the best outcomes in the country as well. So I don't want people to think that that your agency is just leaving people for dead. You actually have some of the best outcomes in this country.
Well, thanks. We actually were just crunching the numbers from last year yesterday. So we have the CARES data, which tells us one picture, but then also I go through by hand and pull all the data for all of our folks. And so for last year, our neurologically intact survival was 13%.
By the way, so everyone knows 8.3% was 2024. So you're almost double the national average, which is something that, again, when I opened up by saying that we all want to be like you, I wasn't kidding. Okay, so
It's the Colorado weather.
Hey, David, is it also though, when you look at those numbers, have you excluded out the asystoles that you ruled out when you got there, like an unwitnessed asystole, which would obviously put the numbers up at a higher level, or does that include those cases?
It includes those cases.
So
That's
it's
fantastic.
everybody you work, basically, just like everybody else. If you work them, they're in the database. You're not, I guess the thing is, you're not cherry picking, is what we're saying. Right.
The ones that get excluded are trauma, obviously.
Yeah.
Right.
And then there's a small handful of, I call them atypicals for lack of a kinder word, but obvious suicide. One where you roll in and they're like, hey, here's the DNR, and we're like, we're not doing anything.
Yeah.
Those.
Right.
So
Fair.
everybody else is included.
Okay. So, and I know that I have a lot of people here who are chomping at the bit. So I'm going to say here, so Tanner, I'm coming to you now, but I'm going to tell David Long to get ready. I'm going to tell Gordon Miller to get ready. And then I know many other people here are ultrasound gurus. So please, I'm going to hear you as well. So Tanner, go ahead.
Sure. Yeah. And thank you so much for this presentation and for writing the paper. I think that
I can't take credit for that. We partner with a med school. It's a DO school called Rocky Vista. And so the students, I give them the data, they crunch it, they write it, I proofread, we go back and forth.
well, I'll say,
I
I mean, the writing's not the hard part, right?
yeah.
Structuring your system so that you're monitoring outcomes, you're having the overreads of these of the ultrasounds, like that's the really important part. And I think everybody should aim to emulate that, right? As we're rolling new technology out, we need to, and not only just assess ultrasound in general, but each specific facet of ultrasound, right? What influences the termination of resuscitation incorporation having the FAST exam? So I think that's really excellent. So in one thing, and I think it's not always necessarily intuitive when we're talking about kind of sensitivity, specificity, when it comes to kind of decision making and diagnostic tests in the field. And so I like that you included in the abstract and in the discussion here, positive predictive value and negative predictive value, which really tells you once you have the test result in your hand, what is the probability that you're right or wrong, right? And so you presented the statistic that about 50% of the time that medics were saying, yes, there's a positive FAST exam. The overread was suggesting that there was not a FAST exam. And so kind of branching off of these false positives. So I kind of have a couple questions about how these false positives would be utilized. I think Wayne Lee said in the chat, so, would patients be taken to the OR simply based on the paramedic read of the ultrasound? Is there another overread that is taking place in the hospital? So that'd be my first question about that. And then second of all, just having a positive FAST exam alone doesn't necessarily mean that you have to go to the operating room, right? I'll speak for the trauma surgery community, despite not being a trauma surgeon. Over the past decade or 2 decades, the management of patients is becoming a lot more conservative, right? They're moving more towards kind of, angioembolization, watchful waiting. There's a lot less laparotomies that are happening in our trauma centers. And so just because you have a positive FAST exam in the field doesn't mean you're necessarily going to be, you need to get to a table quickly, right? So you can respond to those two. And then my final comment before I cede the floor back to you, you know, one question that I've always had in relation to FAST exams in the pre-hospital setting is, does this really improve the ability of medics to identify patients who need the operating room beyond standard assessment findings, right? So like all the studies out there, they look at the ability to identify blood in the abdomen. But, my question always is, well, if the patient was hypotensive, right? They had peritoneal signs, they had a penetrating injury in the box, right? Just based on that, you can send patients to the OR, right? And so is the FAST exam really improving the disposition of more patients, or could you have triaged them just based on the tools we already have in our toolbox? So
Yeah, excellent points. It's one more data set, one more data point. Some of these patients have not gone straight to the OR. So in terms of using that as the trigger of, the positive FAST, boom, go to the OR. No. If it's positive FAST, hypotension, peritoneal, all that, they're going straight to the OR. But as a marker to increase people's degree of concern, so saying, hey, we come through the door, we've got a positive FAST. Well, are we going to go straight to CT and do the assessment there and expedite the work up there, or at least have that one marker to raise people's level of concern of like, hey, where do we go with this? The exceptions we've had are the lady with a stab wound who was her epigastrium, but it was self-inflicted, and she actually had nicked her heart and had a positive pericardial effusion, and that was roll through the door. The ultrasound results are not, when they get to the hospital, are not just relying on the paramedic's word. Frequently it's like, because it's attached to an iPhone, so they've got their iPhone, they're like, hey, these are the images I'm seeing. So people are actually seeing the same images, and based on that, getting another set of eyes on it and making that decision. The pericardial effusion one was looked at that and they were like, right to the OR. Don't even stop. They didn't take them off the EMS gurney. The ectopics we've had was like, hey, belly full of blood. And they're like, yep, we're going. But they were also borderline pressure or hypotensive, and had the rest of the pictures there. So again, one more data point. We're not totally relying on the medic's interpretation. We're getting another set of eyes. We might repeat and I saw Dr. Wayne's comment there, we are frequently repeating the ultrasound if there's any question. But if we're looking at an image that's clear, crisp, good, you can see the fluid, and then based on how the person's doing hemodynamically, that's more of a collaborative approach. And as I was saying, we go to a number of different, not just hospitals, but systems. So we have different teams we're interacting with, different trauma surgeons, some of which we have a closer relationship, some of which we don't know as well, they don't know us as well. And so based upon what we're doing with that, they may take what we give them information-wise more, with a larger or smaller grain of salt. We've paired this with a program called Blood Alert, which is a request, because we don't have blood in the field yet, but we're going live August 4th. We'll have blood in the field August 4th. But right now, we don't have blood in the field. So we have a patient who has evidence of hemorrhagic shock, whether it's trauma, whether it's medical, or the OB, whatever. And they meet the markers in terms of tachycardic, hypotensive, low end tidal CO2, any of that. And we're calling ahead saying, hey, blood alert, which is a request that they have blood in the ER ready to transfuse on arrival. And then we pair that with, by the way, we've got a positive fast. That just ratchets up that much higher to try and expedite care for that person.
Yeah, thank you.
Great, great answers and great question, Tanner. Let me bring in David Long. So David is the executive director of the Tidewater EMS Regional Council, very large area in Virginia, and has conquered the world in many ways. And again, something we all look up to. He got blood across the entire system, and I think you just hit 300 units, if I'm not mistaken. He also said, I'm gonna get ultrasound across the entire system. And so, David, you just heard Dr. Apfelbaum speak. I would like to hear your comments and feedback.
So first, I'd say it's always great to find that when you join a presentation like this, that you just all of a sudden feel validated, because everything that he described here, we've essentially followed that particular model. So we have trained 50 providers across 5 jurisdictions. We're using Equinos or the Cosmos from Equinos as our ultrasound tool. We, like our blood program, probably started in a crawl, walk, run, perspective, where our focus initially is just adult only. Later this fall, we'll actually be shifting to include pediatric population. So working with Children's Hospital of the King's Daughters, they just got 2 new physicians that used to be ultrasound fellows. So they've opened up their facility to bring us in to do our clinical, elements of scans, within that hospital system. So we're very encouraged, about that. Based on a couple of comments, Tanner made, when we talked about how we were going to roll this out, we maintained a view of, we wanted to be able to look at obviously cardiac activity. We wanted to be able to do a better determination, of lungs and need for decompressions or finger thoracotomies, things of that nature. And in that essence of EFAS, when you're really talking about, from the chin to the pubis, I think just the routine nature of which we do these, these scans, we've already had 2 cases in which we had a stabbing victim, much like, Doc described here, where we found, spinal cord injury, but at the same time, also complicated by the fact that we ended up with a tension pneumo that was able to be successfully managed, and et cetera. And then with it, we're able to determine that based on the nature of the injuries, was also losing blood. So prompted a blood transfusion, on the way in. So good outcome, patient discharged, I think it was either day 5 or day 6. But we're having really good success. So for us, we do 2 days worth of didactic training. Then we do, a day, and if necessary, a second day of clinical rotations. We have 2 of our hospitals in region that are our high volume EDs, where we're able to scan both in the emergency department, but also up in the ICU. And then we do essentially field. And in their field, they're required to obtain a minimum of 10 scans, 5 cardiac and 5, EFAST. Those are recorded, and then those are submitted to the physicians group for review and evaluation. And then they go through essentially an oral board process where they essentially evaluate their knowledge, and then they release them to function. So we just released our first 2. We've got another 5 in the queue. And then we would anticipate by the end of the year that we'll have that 50% of our folks fully released to function. And then we'll start capturing the data in the same sense that Doc described here. And then we're working closely with Eastern Virginia Medical School. We have what's called the Commonwealth Health Research Board. And so we're actually doing an ultrasound study in that context of EMS providing, ultrasound. So we're targeting a $200,000 grant that would just substantially expand our program across the region.
Jonathan, before you respond, and then I'll go to you, and then I'll go to Paul. Is that both of you are demonstrating a master class in leadership, in operations, collaboration, getting funding, doing research, like what you just said there in the last 30 seconds. It's easy to say, hard to do. But so Jonathan, I would love to hear your feedback, and then we're going to go to Dr. Pepe.
I actually, it sounds absolutely fantastic. It sounds like a great approach, and I'm so glad to hear that. It's and for you, and for actually anybody on this call, whichever, if we can be of any help here at South Met, we have kind of a maybe I could just email things. We've gotten a lot of contact over the years in terms of, hey, we want to start ultrasound. How can we do it? Or what's kind of a path forward? By all means, reach out. I'm glad to help at all. So whatever we can do to help.
Thank you. And before Molly Tav has a cocktail, Dr. Pepe, go ahead and make your comment. I know you have to leave for your webinar.
Yeah, that's what I was saying. Hey, I did want to say, I think today's going to be a pretty special day. We're going to be talking from the medical director for Kerrville. Kerrville's, city in Kerr County, where all the flooding and all the kids were lost, and all the other adults as well. And he'll be on giving some perspectives. Then, but the thing he's going to be great. We're going to talk about electromagnetic pulse. I think it's a big threat that we do have, and I want you to all begin to learn about it. So that I'll be on with the leading expert out of the FEMA department that are looking at this issue. So, okay, that's it.
Okay. All right, we're looking forward to it. Let
All
me
right.
bring in Gordon Miller. So Gordon's from DeSoto Parish in Louisiana. He's also high flyer, high performer, whole blood, plasma, has a T1 ventilator for cardiac arrest. He's done it all before we have. So Gordon, I know you're doing ultrasound too. Love to hear your comments.
The one thing I will say, just get reps in. You have to do it over and over again. Scan every patient you can. In proper education, I think a lot of the pitfalls in it, you'll see a lot of people that are like, I don't really like it. They'll buy it. They'll use it for a little while. It's because it's like a do one, see one, do one, teach one. And it needs to be an official class. It's what we went through. I have no doubt that anybody from a shower singer to a cover band to a rock star performer can do this. Put all those type people through the courses that we had. Everybody from mid-20s to our director at 68 years old. Everyone took something from it, even our medical directors. It is an absolute game changer in some aspects of it, but I think you can put it like a 12 lead. Just because a patient doesn't have this massive STEMI, if they're having all the signs and symptoms of an MI, we're going to treat that. Just because they may not, you may not see a positive FAST exam or something like that, you're still going to treat those things. But when you start using those in conjunction and see blood and free fluid in the belly or wherever, that, hey, we definitely have a problem. The good thing about it is, I think that, and this is what we learned from our instructors, is if they definitely have fluid there, like effusions, tamponades, things like that, you're going to get a really pretty picture. If you're seeing a really pretty picture, there's fluid there. We use it for, obviously, cardiac standstill. I think about 50% of our PEA patients actually have contractility from what I've seen. Say we have a bleeding patient, we'll go from a FAST exam, start resuscitating with blood, look at IVC filling, look at our volumetric capnography on T1, put all that together, and it makes a very good picture of resuscitation. But I'm glad to see a lot of information getting out there, a great presentation.
Awesome. Jonathan, any comments on that?
No, I totally agree. I was looking at the comments there in terms of, is there a critical mass of trauma? Not necessarily. I think as long as people are using it, it doesn't matter if you ultrasound trauma patients, non-trauma patients, whatever, as long as they're getting, the probe on skin and getting the reps and getting the familiarity with it. Some of my super users, I mean, you blink at them and they'll ultrasound you. So it's awesome, but it doesn't necessarily have to be a high trauma system to be able to have it and utilize it.
Awesome. All right, great. And then I see David put a link there. Let's go with Chief Lou Steinberg. Go ahead.
Hi, so you and Tanner, excuse me, both gave me a great lead-in. You mentioned as far as younger medics using it more than the more experienced ones. And Tanner mentioned, would you know without it? So it gets back into, I read an article once about missing the forest for the trees. Do people, and this is for Dr. Apfelbaum, start concentrating on the tool rather than noticing their patient looks like garbage? Do you find that or not so much? And younger or older?
Usually not so much. Usually the reverse is that they're more focused on the patient and then like, oh yeah, we should do an ultrasound too. One of the feedbacks we'd had on a couple critical patients was we came through the door with the ultrasound, but in one case we didn't have an IV. And we got a lot of negative feedback of, well, what are you guys doing? You're playing with your toys, but you're not doing the basics. You're not getting an IV or an IO. And actually, in digging in the case, we had more than enough crew members on board. And we had one person on each arm working on a line and somebody getting ready to drill the leg. And we had an extra set of hands. So they're the one who did the ultrasound. And they just happened to be the fastest one to get a result. And this lady was morbidly obese and had a lot of issues going on, was hypotensive. And so they rolled through the door without a line, but it wasn't for a lack of trying. And so the initial feedback was, oh, you're playing with your toys, but missing taking care of the patient. And then a lot of reassurance and follow up and education to be like, yeah, not the case. I understand where it looks like that. But then also driving the point home to the crews that absolutely don't miss the ABCs for getting all the way down to you for ultrasound.
Yeah.
Okay, so it's largely being used as an adjunct, not as a replacement, in other words.
Exactly.
Right. So,
Okay,
so basically, part of the training has to be, where does ultrasound fall in the sequence of your care plan, which is a great point. Because you're right. The hospital will find anything to look at to say, hey, you're not doing things in the right order. Excellent. Anybody else out there who is who feels strongly one way or the other? Are there people out there who feel against that ultrasound's a waste of time and money and we should throw it in the garbage? Anybody out there? We want to hear all points of view. All right, so we're at 11:37. So here's what we'll do. I'm going to give you the last word, Dr. Apfelbaum. So there are people out here who are thinking of starting something. They're not sure whether to start something, or they've started something and it hasn't worked. What's your recommendation as far as someone who has done this for many years? What are your top, let's say 1 or 2 things to do today in order to make this type of process work at their department?
I would say baby steps, the crawl, walk, run approach. So let's say you're trying to roll it out and you're just not getting a lot of traction. Stop, back up a little bit, identify the people who want to be the champions for it, the people who are the most excited about it. Start small, whether it's TOR, looking for cardiac stents, pick one thing. Don't try and scan the person stem to stern and get every ultrasound study available up to speed. You're not going to do it. So start small, pick one thing, get people comfortable with it, then show what your data is doing in terms of, are we making a difference? Are we utilizing this successfully? And then you can build on that, get more people trained, expand your scope. Is there something within your system where this is specifically useful? So like during COVID, when we initially were trying to corral all the patients we thought were COVID at one facility. So great, if we look at lungs, are we getting information from that? Are we using it for termination of resuscitation? So taking a stepwise approach and building on your successes.
So great comments. I want to go back to Tanner for the last word here, because Tanner, you're a paramedic, you're an MD PhD student, you're going to be leading this profession, no doubt, in some years. My question for you is, what do you want to see as a data scientist, as a paramedic, for you to say, I'm sold on this?
Yeah, I think you could probably guess my answer. I need a randomized clinical trial, right? We need, right? We would need to, right, hand out ultrasound devices, maybe have some kind of software built in where, half the time you're able to view the screen, the other half of the time the screen's turned off, and you have to try to acquire views. I don't know. It would have to be a randomized controlled trial that actually shows utility in terms of patient-oriented outcomes, right? I think that is a tall order. It's something difficult to do with something like, an imaging study, especially in the pre-hospital environment. But I look forward to seeing more data, specifically in the context of this discussion with regard to trauma triage. I do have a little bit of skepticism that the FAST exams in this context are going to provide kind of additional utility in terms of triaging patients beyond standard physical exam and vital signs. But I would love to be proved wrong.
Yeah, well, I think that the number that stood out to me the most was your TOR rate of 58%. I'm embarrassed to tell you what it is in South Florida, because we have the worst termination rates in the country. Why? Because people recognize that if they start to terminate unseen, then they have to do other things unseen that they've never been trained to do. Talk to families, console families, wait for the ME to show up. So that's I know that's a whole nother conversation, but and so Tanner, to your point, maybe the FAST exam is not the first 3 types of exams you're going to do, but clearly at South Metro they have enough experience and enough confidence and enough feedback on from the actual scans in real time, et cetera, from their docs, that they can get to that point. I'm not so sure. Is there anyone on the call who's doing FAST exams besides South Metro? I wonder. John, do you know anyone else who's doing them besides you?
I believe so, but off the top of my head, I'm totally drawing a blank on which HD specifically.
But it's not where people would start more than likely. You would agree to that?
Not at all. Not at all.
Okay. So it's almost like the final mile of the marathon, in the ultrasound marathon, is the FAST exam, probably.
Well, actually, peripheral IVs, I think, is the final mile, because that's even though it intrinsically seems kind of simple. Oh, look at the vessel and put the needle in it. It takes a lot of eye-hand, three-handed skill technology for that. So I think FAST is the one right before that. But
what about so during cardiac arrest, people were throwing the probe and trying to put it on the chest to look at the heart, and it turns out that was causing massive pauses. Are you putting the probe on the carotid to look for, during the pulse check, to look for pulses instead of using your fingers?
We're not yet, but we've been talking about that because there was some really interesting stuff from that. But we're doing more epigastrium, so looking up underneath the rib, so we can actually still do it while compressions are going on.
Okay. All right. It turns out that we have probably a lot more to discuss. I know here that Chief Reardon, I'm going to be giving him your number and David's number and Gordon's number, because I know that he's interested here, or I know there's people interested all over the country to do this, but learning it from the people who are doing it the right way, and both you and David really presented something that's a very formidable and the right way of doing it. So thank you so much for joining us. Thanks for submitting and contributing to the evidence base, as Tanner mentioned. We love the fact that you're publishing this stuff, and we appreciate it. I'll put it on YouTube if that's okay with you. And we appreciate everybody coming. Have a very safe weekend. And signing off here from the Duxbury Fire Department in Massachusetts. Have a great week, everybody, and we'll see you next.
Thanks for having me.
Hey, before